Greetings, dear learners. In the last class, we were learning the toxidromic approach to the management of poisoning. Under that, we covered the classification of toxidromes and then we took the individual toxidromes in detail. And in that, we read the RRSIDDA approach to the management of poisoning, that is resuscitation, risk assessment, supportive care, investigations, decontamination, enhanced elimination, antidote, and then disposition. And taking the individual toxidromes, we discussed anticholinergic toxidromes, cholinergic toxidromes, symptomimetic or adrenergic toxidromes, opioid toxidromes, and sedative hypnotic toxidromes. Today, we will learn the remaining toxidromes. Coming to the serotonin toxidromes, it is either a side effect of the pro-serotonergic drugs taken in the pharmacological dose. Coming to this point, coming to the serotonin toxidrome, then correct it. So this is basically the side effect due to the coming from this. Today we will learn the remaining toxidromes. Under that, coming to the serotonin toxidromes. It is either a side effect of pro-serotonergic drugs taken in the pharmacological dose, facilitated by the drug interaction, or as a result of an overdose. It reflects the increased brain serotonergic activity induced by substances such as serotonin reuptake inhibitors, SRIs, then the monoamine oxidase inhibitors, MAO inhibitors, lithium, tricyclic antidepressant, ectacy, and the L-tryptophan. All these can cause or produce the serotonin-like syndrome that is known as serotonin syndrome. The clinical picture of serotonin toxidromes includes the neurological disorders, including agitation, confusion, hallucination, myoclonus, tremor, pyramidal syndrome, seizure, and coma. Autonomic disorders such as mydriasis, sweating, tachycardia, tachypnea, hypothermia, chills, hypotension, diarrhea, and even the respiratory arrest. Then virological abnormalities like the hyperglycemia, leukocytosis, hypokalemia, hypocalcemia, disseminated intravascular coagulation, DIC, lactic acidosis, and rhabdomyolysis can be presented in this serotonin syndrome. The clinical diagnostic criteria were defined by the Sternbach. Diagnosis of the serotonin syndrome requires firstly to rule out the metabolic or the infectious etiology or withdrawal complications, and secondly to differentiate the clinical finding from the other toxidromes. So the diagnosis is basically ruling out of the other findings and then doubting about the serotonin features. So this will confirm the diagnosis of serotonin syndrome. Myoclonus is usually at the forefront and should be pursued as a priority. Serotonin syndrome occurs more frequently than it is reported, as it is underestimated due to inherently to the signs observed. It can be life-threatening also because of the DIC and the rhabdomyolysis. During this complication, the 5-HT1A and 5-HT2 receptors are involved that you already know the functions of it under the pharmacology. The identification of these toxidromes requires the discontinuation of the suspected drug or looking for any drug interaction, and that shall be withdrawn, or the symptomatic approach to the prevent the malignant hypothermia, multi-system complications, and the other complications. In severe form for the management, extensive cooling, respiratory support, and muscle relaxant shall be given. No specific treatment, however, has been effective for the serotonin syndrome in the randomized control trials, but the use of saprohepatidine, that is serotonin receptor antagonist and histamine receptor antagonist, is seen to be effective in the dose of 12 mg orally followed by 4 to 6 mg every 6 hourly. Along with it, dantrolene is also seen to be effective in the care of the serotonin syndrome. Intravenous fluid for rhabdomyolysis is the supportive care or the management for the symptomatic patients of the serotonin syndrome. You can see in this picture, the patient is presenting with the mental status changes, autonomic instability, neuromuscular hyperactivity, and this all the triad when we will find in a patient, then this is suggestive of the serotonin syndrome that could be due to SSRIs, lithium, mepridine, triptans, MAO inhibitors, cocaine. SSRI plus MAO inhibitors further increases the risk. So the patient's features, if you remember this picture of the anticholinergic syndrome. So this guy in the anticholinergic syndrome is saying that this girl is having the similar symptoms to me. However, this has additional features that of diaphoretics, nausea, and the vomiting. So in the anticholinergic, there was the dryness, whereas in the serotonin syndrome, all the three features, central nervous system involvement, then muscular involvement, and the autonomic instability, all the things are involved similar to the anticholinergics. However, here there will be dryness. So this guy is saying, I am dry as bone and sea is hot and wet. So this is the main difference between serotonin syndrome and anticholinergic syndrome that must be seen on the patient. Then the cogwheel rigidity will be seen in the patient, hyperreflexia, bruxism, sweating, then the tachycardia, vomiting, all these will be seen in the patients of the serotonin syndrome. In the cogwheel rigidity, there is initial rigidity, then after that some pressure, it get relaxed. This is called seen in the patients. Then this is the table showing the diagnostic criteria that was defined by the Sternbach. So the history is important in this part, where the recent introduction or increased dose of the pro-serotonergic agent in the absence of modification of the dose regimen of the current neuroleptic medication. If this type of history is there, then you have to look for the clinical signs for the presence of at least 3 of the following signs. That could include if the higher functions involvement, then the confusion, agitation, coma, anxiety, minor mania, seizures, headache, insomnia, hallucination, dizziness. Autonomous system, their fever, increased sweating, sinus tachycardia, hypertension, mydriasis, tachypnea, hypotension, chills, nausea, flushing, diarrhea, hypersalivation. Then neuromuscular involvement presents with the myoclonus, hyperreflexia, muscle rigidity, hyperactivity, tremor, incoordination, clonus, bilateral Babinski sign, and the nystagmus, trismus, bruxism, opisthostenus, and paresthesia. If any 3 of the signs are present in the patient with a history, then this is suggestive of the diagnosis of infection, metabolic disorder, neurological disorder, or other toxidromes and the serotonin syndrome. So you should rule out that it exclude the infection, metabolic disorders, neurological disorders, or other toxidromes. And then if you have these signs and this certain type of history, then this is the surety of the serotonin syndrome. So this way we will identify the case of serotonin syndrome and manage accordingly. Then the neuroleptic malignant syndrome. Neuroleptic malignant toxidromes. It is basically the undesired effect of taking neuroleptics and less often a consequence of an overdose. This syndrome should be considered in a set of the case where the patient present with hypothermia, that is body temperature more than 38 degrees Celsius, confusion, impaired consciousness, generalized hypertonia with osteotendon hyperreflexia, axial rigidity of the muscles, sweating, hemodynamic instability, as well as rhabdomyolysis. If such a picture is there, then this is suggestive to neuroleptic malignant syndrome. You can see in this picture that the patient is saying that I had started on the antipsychotic 2 to 10 days ago. So he started the neuroleptic drugs, and then he is presenting with an increased heart rate, high temperature, high blood pressure, or the increased respiratory rate, and the important is hyperthermia, means hyperenergic activity. And then on the investigation or the examination, there is a fever, antimuscarinic symptoms, leukocytosis, tremors, elevated CPK, rigidity, and then it all the suggestive of the neuroleptic malignant syndrome. The features that will be the fever in this neuroleptic malignant syndrome exceed up to the 43 degrees Celsius and may be the life-threatening to the patient. The onset of signs ranges from the few hours to the 7 days for the short-acting neuroleptic and 2 to 4 weeks for the long-acting neuroleptics. This set of manifestations should be distinguished from the malignant hypothermia associated with the serotonin syndrome. As a result, in that case, that is a result of ecstasy or the other amphetamines and other serotonin drugs or a hallucinated anesthetics. The identification of this toxidrome requires an urgent symptomatic treatment with copious rehydration and the cooling in the patient. The dantrolene and the bromocriptine have been proposed as a specific treatment. The bromocriptine is given as the 5 mg thrice a day and dantrolene in a dose of 1 to 3 mg per kg body weight 4 times a day. And then along with that, other supportive measures are indicated in this neuroleptic malignant syndrome. So this neuroleptic malignant syndrome symptoms shall be ruled out with the serotonin syndrome and the anticholinergic syndrome. And the history of the starting the antipsychotic drugs, particularly the neuroleptic drugs. So this is all suggestive to the neuroleptic malignant syndrome. So with this, we conclude the toxidromic approach to the poisons. Some of the other toxidromes that are possible could be snakebite toxidromes, and then withdrawal symptoms of psychotropic drugs, effect of membrane stabilizing agents that is used in antiarrhythmics, metabolic acidosis, and with the elevated anion gap, and various other toxidromes where the constellation of signs and symptoms are a common and having a common features. They all will be categorized under the toxidromes, and a common approach of management may be considered in such patients. So the basic idea behind the toxidromes is that the etiologic evaluation in the presumed poison patients required a targeted history, also a thorough physical examination, then ECG, and if necessary routine biological analysis to find a toxidrome. And once a particular toxidrome is decided, its management becomes easy and defined even without knowing the exact poison. The only toxicological analysis that is useful to establish the diagnostic certainty and prognostic evolution is the measurement of blood concentration of the toxic agent guided by the initial clinical approach based on the toxidromes. So the diagnosis of confirmation of the poison can be only done by the evaluation of the blood concentration of that poison. That is the confirmatory test about the poisoning. However, in general, the management in the casualty or the clinicians where the toxicologists are working, the most of management are done on this major guidelines only, and the patients are surviving even in the cases where the poison is known, and mostly it is the situation is there, the poison is unknown, the patient is not going to tell what he has consumed exactly, and many more circumstances like this is there. So the clinician is identifying the management protocol based on this toxidromics approach. So with this, we finish our toxidromes, and then with this we started from the under the broad guidelines to the management of poisoning, that is immediate resistive measures, removal of unabsorbed poison from the body, removal of absorbed poison from the body, administration of antidote, then the symptomatic management. Under that we covered the toxidromic approach, other symptomatic treatments for the management of the hyperthermia, hypothermia, hypertension. We all covered it under the various topics of the like immediate resistive measures. We almost covered most of the symptomatic treatment to the patients. The remaining of the treatment will be covered along with the individual topics, and then we will go for the adequate follow-up and the nursing and psychiatric care or other supportive care to the patient. Then we have to provide, after the patient is stabilized and the initial care has been given, then the job of the hospital or clinician is to provide adequate follow-up and the supportive care. Following resuscitation and the risk assessment, supportive care and disposition planning can begin. So once the patient is stabilized, then how you should discharge the patient, how you should shift in the observatory room, this all will come under the adequate follow-up, and then how you send the patient and call again at what interval to look for any complications. You make aware about those complications, and so that this will prevent the further complication in the patients. So poisoning, morbidity and mortality usually result from acute effect of the toxin on the cardiovascular, central nervous system or the respiratory system. Support of these and other systems for the duration of the intoxication will ensure a good outcome for the vast majority of the acute poisoning cases. Monitoring is essential to detect the progress of the intoxication and the timing of institution, escalation and withdrawal of the supportive care and other measures. An initial period of the close observation in the emergency department is usually appropriate once the patient is stabilized. During this time, the patient's clinical status is monitored closely to ensure that it correlates with the previous risk assessment. If the early complications are expected, like the decreased level of consciousness requiring intubation in following 2 hours, then preparation can be made to secure the airway as soon as intoxication declares itself and before the patient is moved elsewhere. If unexpected deterioration occurs at any time, the clinician's priorities revert to resuscitation prior to revising the risk assessment. So, we keep the patient in the observatory room after the stabilization, and even the patients who are coming for the poisoning, if they are not having that much of risk, then also shall be kept in the observatory room for a certain period. Then after, if there is no further complications or the issues, then we decide whether to discharge or to keep in the further observation, or if the patient deteriorates, then we have to again stabilize them according to the stabilization in resuscitative measures. The duration of the observation depends on the agent ingested, the formulation involved like sustained release preparation, and the potential complications like patients with a significant beta blocker and the tricyclic antidepressants with a deliberate self-poisoning develop symptoms and signs of major intoxication within 2 to 4 hours of ingestion. In contrast, the patients with a sustained release calcium channel blocker or valproic acid deliberate self-poisoning may take 6 to 12 hours to develop signs of the major toxicity. So, this will decide our observatory period for the toxic poisoning. Then the disposition from the emergency department depends on the current and expected clinical status of the patient. If the specific complications are anticipated, then the chosen inpatient clinical area must be resourced to detect and manage them. The accuracy and the skill of the initial management and the risk assessment is vested if the subsequent plan of management is not documented and communicated to the treating team. So, good practice includes the documentation of a comprehensive management plan that informs the patient as well as the team that are the caring of to the patient. In the comprehensive management plan, we should look for the expected clinical course, potential complication according to the individual risk assessment, then the type of observation and the monitoring required, then endpoint that must trigger the notification of treating doctor or further consultation, the management plan for the agitation or delirium, criteria for changing the management, then provisional psychological risk assessment with contingency plan should be the patient attempt to abscond prior to formal psychological assessment. All this should be documented and properly planned in a proper manner before the start of the management. The needs of the vast majority of patients can be met in the emergency department and emergency observation unit or ICU, intensive care unit. The emergency unit is the appropriate for the ongoing management of the most of the acute poisoning, where the general supportive measures outlined below can be provided. Criteria for admission to an emergency observation unit following acute poisoning include ongoing cardiac monitoring, adequate sedation where achieved or not, clinical deterioration anticipated. After a pause, please delete last line. So, the criteria for shifting the patient from the emergency care to the emergency observation unit following acute poisoning includes that no more cardiac monitoring is required, then adequate sedation has been achieved properly and the patient is stable now, then the clinical deterioration is no more anticipated, then these all are the suggestive that we can keep the patient under the emergency observation unit, and where after a certain period of observation we can discharge the patient. Then apart from the basic guidelines to the management of the patient, patients shall be taken care for the general measures which are very essential to prevent complications and helpful in early recovery of the patients. The general supportive cares that for the patients include the nutrition. Care of the nutrition is very important in the early recovery of the patient. So, good care of the patient, nutrition shall be done in the hospital, and even after discharge, the advice for the healthy nutrition shall be given. Then pulmonary hygiene is very important. The secretions and every discharges from the respiratory tract shall be properly cleaned time to time, so that to avoid the respiration infections and the respiration pneumonitis. Then bladder care, indwelling catheters shall be properly cared and cleaned properly, changed on time, so that it can itself be source of the infection to the patient and further complication. Then prevention of the pressure areas, if the patient is admitted longer, so the pressure source may develop. So proper care of the patients, the position of the patient shall be changed frequently, and if the pressure source develop, then the proper dressing and the management of those is the necessary supportive care for the patient. Then thromboembolism prophylaxis for the long-term bedridden patients, this may be required to prevent the thromboembolism. Then mobilization as mental status changes resolve, then the moving the patients, giving the proper surroundings, walking and everything is the important for the psychiatric wellness of the patient. So all these cares shall be given to the patient under the adequate follow-up and the supportive measures. Then after nursing care, nurses have a very important role in the management of the patients. They care the patient, they provide the medical care, they follow the advice of the doctors, giving timely medications, care of the other cares related to the patients, and then they have an important role in the adequate follow-up and the supportive cares, taking care of the nutrition, taking care of the bed sores, indwelling catheters and all those places, nursing care is very important. Then the nursing care has a very important role in the prevention of the poisoning. Prevention of poisoning is the important aspect of the nursing care. This involves educating patients and the families about the dangers of the toxic substances, implementing safety measures to prevent accidental exposures, identifying patients at the high risk for intentional poisoning, and implementing appropriate preventive measures. Then the ethical and legal formalities related to the poisoning shall be done also by the nursing staffs. Nurses involved in the management of the patients with the poisoning should be aware of for the ethical and legal consideration involved with the poisoning cases. This may include obtaining the informed consent for the treatment, mandatory reporting requirement for certain types of poisoning, and considerations related to the patient privacy and confidentiality. With appropriate nursing management, patients with the poisoning can achieve a good prognosis and return to the normal lives. With this, finally, the psychiatric care of the patient is very important. As most of the cases of the poisoning are reported to be due to the suicidal intention, so Mental Health Care Act 2017 decriminalized the Section 309 of IPC and stated that any person who attempts to commit suicide shall be presumed, unless proved otherwise, to have severe stress, and the appropriate government shall have the duty to provide care, treatment, and rehabilitation to a person having severe stress and who attempted to commit suicide to reduce the risk of recurrence of the attempt to commit suicide. Prior to this, the attempt to suicide was a punishable offense with 1 year of the imprisonment. So with this decision, all the patients who are committing the suicide are basically the patients of the psychiatry. So general advice to all those patients who are committing suicide shall be given for the psychiatric management or psychiatric assessment and the psychiatric consultation. It has been reported that most of the poisoning cases are suicidal in nature. Even that is, a study shows that more than 75% of the cases on the poisoning are suicidal of nature, followed by the accidental. And among the suicide attempters needing hospitalization, poisoning is the most typical method practiced. So para-suicide cases are maximum with the poisoning cases, because other method of the suicide are mostly successful suicide. So the poisoning cases presents mostly in the para-suicide condition. So in view of this, majority cases of poisoning need the care of their mental health. So once the patient is out of the danger and stabilized, he shall be referred to the psychiatrist for the care of their mental health. So we must know that any patient who has taken an overdose or manifest suicidal ideation should get the psychological assessment and support as early as possible. The initial evaluation can be performed prior to total clearing of the patient's sensorium, but a final assessment should not be made unless the patient is completely alert. Recognition that the patient is possibly suicidal with a precise analysis of potential for the suicide is essential. Carefully analyzing the patient's psychological state, like depressed, uncooperative, unresponsive, agitated, anxious, violent, or psychotic, will allow for the realistic appraisal of the psychological alternative with respect to immediate and long-term management, disposition, and continued follow-up of the outpatient care. It is estimated that among adolescents, suicide accounts for a third of all unnatural deaths, while in college students, suicide is the second leading cause of the unnatural death. According to one survey, oral injections account for 78% of the cases. 13% are inhalational, while 5% are due to the parenteral intake. Patients suffering from the depression commit suicide 15 times more frequently than the general population. Alcoholics and chronic dialysis patients have the suicide rate of 6 times higher than the population at large. After the age of 40 years, the suicide rate begins to climb with a dramatic increase seen after the age of 65 years. Women attempt suicide 3 times more often than the men, but men are successful in finally committing suicide in the ratio of 3:1 compared to the females. Significantly, 75% of those who commit suicide do so after seeing a doctor. So all these informations suggest that we should be alert about the suicide attempters, and we must have the knowledge of the pattern of those who are committing the suicide. Usually it is the family physician, not a psychiatrist, who sees the patient first, and many of whom have clearly needed the psychiatric support, but because of lack of awareness or lack of understanding, the family doctors did not advise for the psychiatric consultation, and they finally committed another attempt of suicide and they died. With the prompt recognition and referral, many suicides may be prevented. A patient with a past history of previous suicide attempts, vague health problem of recent onset, recent surgery, alcoholism, drug abuse, and mental unsoundness, especially psychosis, is at high risk. Stress is also a major factor leading to suicide ideation. Recent bereavement, loss of job, financial loss are well recognized as a trigger factor to the suicide. Hypochondriosis, pessimism, hopelessness, and other signs of depression may signal a potential suicide and should alert the clinician. Unfortunately, there are a number of misconceptions about the suicide. Like many people believe that those who talk about the suicide will never actually commit the suicide, and those who resort to frequent suicide gestures are not really serious. However, studies show that all those who successfully commit suicide, 80% have threatened to do so in the past and may have been made the previous attempts. So, this conception shall be corrected and shall be looked if someone is giving the history, giving the suicide behavior or talking about the suicide. It is therefore essential that every patient who talks about suicide or who presents with a suicide gesture, no matter how trivial, he should be referred to a psychiatrist before leaving the emergency department. Today's psychological assessment has become an important component in the comprehensive evaluation of the toxicological emergencies. It has to be initiated in every case by interviewing the collateral sources, accompanying family members and the friends before talking to the patient himself. Delay in obtaining psychological information can have serious consequences. In cases where an overdosed adult patient may have small children who were left unattended. So, with this approach, we can prevent many of the suicide cases. And particularly, although this is not of much of our concern, but briefly, what the management protocol that the psychiatrists follow is, we will know in the brief, that is, they assess for any immediate danger. If it is not there, then they will document it, provide relevant treatment and monitor the patient. If there is an immediate danger, then is the outpatient treatment is possible? If yes, then the restrict means provide the relevant treatment, identify contact, involve other, provide emergency contact numbers, regularly reassess the risk factors, and stay in contact with the relatives, look for the means through which he can commit suicide and all those factors, surroundings that is affecting his depression or all the things that can be looked upon. Then if the outpatient treatment is not possible, then hospitalize the patient, provide relevant treatment, maintain contact, document and then follow up. Under the psychiatric measures, the technique to management the acute suicidal crisis includes the remove the agent or the stressors, and then the safety planning, then planning for the future, immediate futures, Then decreased isolation, social surroundings shall be increased, social friends shall be involved and they must be told about the situation. Decrease the high risk behavioral factors, decrease high risk environmental factors. Then the emergency somatic treatment that may be provided for those inpatient cases may be the electroconvulsive therapies, lithium, antidepressants. Ketamine is seen to be very helpful in those who are committing suicide. Then clozapine, measures to control acute anxiety and agitation, all are taken care by the psychiatrist in the management of this suicidal behavior. So in the next class, we will take the further other topics, and with this, thank you so much for your patient listening. Thank you.